Viral Shah, over to you, sir.
All right, great. Thank you. I would like to thank from my bottom of heart to Dr. Patels, Mayurbai Patel, Yesh Patel, everyone. And as I said earlier, that I'm hoping that in 2022, I think I will see you guys in person. So again, thanks for inviting. And I think it's a beautiful morning start for you guys, from a yoga to great talk by Dr. Akhtar, and I'm going to build on that talk actually, and this will be a very interesting case for you guys. So let's see. If you haven't had your cup of tea, please have that, because I think this case will require some kind of a tea or coffee to have your brain, be activated and answer some of the questions. So please. And I'm without tie. In my pre-recorded session are a tie because it's at 10:30 p.m. in Denver. It's a snowing outside with a -3 degrees Celsius temperature. So I am a little bit off right now. Anyway, next slide, please. Okay, so I'm gonna tell the history of this patient. And actually, I'm seeing this patient for about now 7 years. And I'm going back into the chart and telling you the story of her life, starting as like when she was 21-year-old. She was 21-year-old, Filipino descendant American. She migrated when she was in high school with her father at the time. Found to have a high blood sugars on a routine screening. So now, you know that in many countries, they do have like an annual physical examination. And that concept has even now, arrived in India too. And they do all CBC, CMPs, and annual blood test. So this is how it was picked up. Vitals and everything was normal. She was a very skinny to begin with a BMI of 18 kilogram per meter square. In a past medical history, she has a hearing loss. Don't know why, but she was on a hearing aid and doing perfectly fine. No issues so far. In a family history, mother had probably type 1 because we don't know. She was in the Philippines at the time. This person remembers that mom was taking insulin. So I'm guessing it was type 1 diabetes. At the time when I saw her for the first time, father had no diabetes, but then I learned that now father has type 2 diabetes. So father is recently diagnosed with type 2 diabetes, sorry, on oral medication, and he moved back to Philippines. So now this lady is by herself in USA. There are no siblings. She is the only child, so we don't know the history in her siblings. The fasting glucose was 290 milligram per deciliter, and random glucose was 320 milligram per deciliter, done at 2 separate occasions at the primary care's office. And these are venous glucose, not the capillary glucose, not through glucose meter. She, of course, has a symptom. She has a polyuria, polydipsia. She had a recent weight loss as well. She's already skinny, and she also had a weight loss. So my question to you guys, what do you think? What is the diagnosis here? Uh, this is not a poll question. I'm sure that everyone knows that there is a fasting glucose of 290. That's a definitely diabetes. I'm not saying type 1 or type 2, but definitely diabetes. According to the American Diabetes Association criteria, if you're fasting plasma glucose, now remember, I have to stress this because whenever I talk in many Indian forums, I have to remind people the definition is based on a plasma glucose, not based on a blood glucose or not based on a serum glucose. There is a difference between serum, there is a difference between capillary glucose, there is a difference between venous glucose. So this is a plasma glucose. And if it's a greater than or equal to 126 milligram per deciliter, then the person has diabetes. And the fasting is defined as at least 8 hours of fasting. So remember that part too. 2 over postprandial glucose after OGTT, that's a 75 gram glucose. Now, when I was in India, practicing as an endocrinologist there before moving to the US, this is a very, I feel like a bad concept. Fasting and 2 over ppg, 2 over ppg is not equivalent to 2 over postprandial after OGTT. So that ppg is actually a random glucose. Don't call it as like a ppg. And if after 75 gram of glucose. Now remember that part, the glucose must be anhydrous glucose, okay, not anhydrous glucose. In India, you don't have a hydrous glucose. So when you use a glucon D, you have to use 82.5 milligram of glucose, not 75 milligram, sorry, 75 gram of glucose. So I'm not talking about, the details of those nitty gritties, but I feel like it's a really important for you guys to understand some of the aspect of definition of diabetes. I think majority of the time we are making a mistakes in defining diabetes. Or A1C greater than or equal to 6.5%, and A1C must be done by DCCT standardized NSGP method. Okay, so if you are doing, let's say, point of care A1C, that's not considered as a diagnostic of diabetes. Or if the patient has a symptoms, like for example, our patient has a symptoms, and if you do random glucose anytime, whether it's a non-fasted or after meal or anytime, and if it's greater than or equal to 200 milligram per deciliter, then the person has diabetes. So our patient definitely has diabetes. I think no one would have a doubt about that. Next slide, please. But the question is that what kind of diabetes this person has. So I think there is a poll. Let's go to the poll. What do you think? Whether it's a type 1, whether it's a type 2, or whether it's an immune checkpoint inhibitor related diabetes that Dr. Akhtar just spoke about. I'm going to wait till I get a green signal from Dr. Yash Patel.
Sure.
I don't know how this poll works.
So the poll has started and it is going well.
Perfect.
So we have now 10 seconds to wait for. And we have three options, type 1,
I can
type
wait for
2,
30 seconds, so
3.
no worries.
All right,
Fine.
pleasure. And we'll have the display on our screen also, how it went through.
Sure.
Yes.
All right.
Pleasure.
As I said,
We
that
are-
drink your tea, drink your coffee, think about this case. I already told you that she has diabetes. We do not have a doubt about that. The doubt is what kind of diabetes it is. So let's think about it. All right.
So we got the
So
poll.
30%, 37% say type 1 diabetes, 12% say type 2 diabetes, and 50% said atypical diabetes. Very interesting. Okay, I'll talk more about that. Okay, next slide, please. All right, so I'm going to give you more information. So according to the ADA criteria, there are various types of diabetes. Okay, don't just think about type 1 or type 2. Type 1 can be divided into type 1A. That means if someone has an antibody positive, that's type 1A. Type 1B is that about 10% of the patients who are typical like type 1, they require insulin, but they are antibody negative. So that's called as type 1B. Type 2 is, we know that, and I call this very clearly, that type 2 is actually a diagnosis of exclusion, meaning by that, if you don't think of anything else, then it's type 2, because there is no diagnostic criteria for type 2 diabetes. So absence of other diabetes are type 2 diabetes, or type, so you have to think about actually ruling out different kind of diabetes before you can stem someone with type 2 diabetes. And now, in this field, doing my fellowship from a PGI Chandigarh, working as an endocrinologist for almost 9 years now, I feel like it's such a confusing that each time I see a patient, it's hard to classify actually. And then sometimes you rightly classify the person after the person is having diabetes for maybe 10 years, maybe 20 years and 30 years. I have revised the diagnosis of diabetes like after people have diabetes for 30-40 years. So it's just I'm telling you that it's diabetes is not that simple. It's a complex. Other type of diabetes are monogenic diabetes, like an MODY, or neonatal diabetes, or some kind of a genetic defect, like in type 1 or type B insulin resistance, or a pancreatic diabetes. I have seen a lot of FCPDs in India when I was in India. It's called as fibrocalculous pancreatic diabetes. So people, this is more common in southern India rather than western India, but that we have seen a lot of cases in a Punjab area as well. If you do an X-ray of abdomen, you will see a calcification in a pancreatic area, and that's FCPD. Of course, diabetes related to drugs, other endocrinopathies, and again, remember, I cited the reference of 2014, and now we have an immune checkpoint inhibitor diabetes as a part of, like, this classification as well. So diabetes is a various kind, and it's unfortunate that we just stuck to type 1 and type 2 most of the time. We are not thinking beyond that box and thinking about different type of diabetes. Next slide, please. So this person, of course, we wanted to rule out the type 1 diabetes. So we did a GET65 and ICA 512. Now, this person is a 47-year-old lady right now. And I'm talking about the history, which when she was 21-year-old. So at the time, we could do 2 antibodies. Now we are doing 4 antibodies. GET, ICA, IA2, and or IA2 or MIA, and the zinc transporter, that's a ZNTZ8. And the C peptide was 0.9, not bad, but I think she was not making enough insulin. That's how I can say. C peptide is very, don't take that as a face value, because C peptide can be influenced by multiple factors. It's not the perfect marker. It is a surrogate marker of beta cell function. So I can just say that this patient is negative for antibodies and has some beta cell, but not probably enough, because she has hyperglycemia too. So now with this information, what are you thinking about type of diabetes? So next slide, please, and let's have a poll. Type 1, type 2, or other type that I don't know right now.
Yes, we have the poll live. Type 1, type 2, or atypical. And like you mentioned, it is always, so Dr. Viral Shah always share these things. The diabetes care is on opinion based, and it's on individual care. So how you perceived, yeah.
Yep, it's a unfortunately there are no rocket science or rules for diabetes.
So yes, we have the voting going through.
Okay.
Yes. Yeah.
All right, pretty much the same response. Yeah, that means the people are still sticking to their choices, which is good. That means you're confident. And I like that 50% response. I think a lot of students who are probably reading for exams, they are getting smart, because they know that this is a interesting case in some kind of a conference. It's not going to be type 1, right? So let's click on atypical diabetes. I think that's what I see here as 50%. So smart people. Okay, next slide, please. All right, so further more history. So what we thought at the time, this was 20 years back nearly, right? Considering her young age, BMI of 18, so she was actually on the side of an undernutrition, family history of type 1 diabetes on the mother side, and low normal C-peptide response. So we diagnosed her as a type 1 diabetes at the time. And we started her with the insulin therapy, so long-acting and short-acting insulin, multiple daily injection. She had a very poor control with the A1C between 8% to 10% for the first 10 years of life, so between 21 years to 31 years of her age. In 2005, she developed ESRD, end-stage renal failure, with the GFR less than 30, I think, at the time. So investigated thoroughly, and renal biopsy was done, because generally we don't see a renal failure within 10 years of diabetes, which is very unusual in this case. But biopsy suggested some changes which were typical of diabetics, diabetic nephropathy. So she was diagnosed as a diabetic nephropathy. But then she was lucky to find a relative, and that person was willing to give a kidney. So she got a living donor kidney transplant in 2005 or 2006, around that time. She still has a normal renal function. So that transplant was very successful, stable, and there was no rejection. And this happens with all patients with diabetes. Once they develop some kind of a complication, they becomes very active, and they feel like, oh, now I have to manage my diabetes very well. So that's actually happened with her too. And she was very active in managing her diabetes. She decided to go on an insulin pump to lower her A1C, and her A1Cs are 5.6, between 5.6 to 6.5 after that incident of renal failure in 2005. So has done very well, exceptionally well, I would say. And since 2013, I followed her, but between 2005-11, I think she was not requiring. So when I saw her for the first time, I was like, she's so skinny. Generally we see type 1s which are not that skinny. And she had some atypical development of complications. As I said, that the complications do not happen that fast in whether it's a type 1 or type 2. So I thought that there may be something wrong here. So I tried to rerun her C-peptide levels and other things, but everything came back as the same as before. The only exception is that she's keep losing her weight. Her BMI is now 16.8. Excuse me. Things have actually went downhill in 2015 when she developed seizure. It was not a typical seizure. It was not a generalized tonic-clonic seizure. She found unconscious in her apartment. So I think the neighbors called police. They came, they found that she was unconscious. She was lying on the floor. They, of course, they checked the blood glucose. The blood glucose was normal. So she did not have a hypoglycemia. And they concluded at the time that she might have had a seizure and that's why she became unconscious. But again, we don't know that right now. MRI was done in emergency, suggestive of cerebellar atrophy. Please stay to that slide. Don't rush through. MRI was suggestive of an cerebellar atrophy. There was no infarct, so there was no suggestion of a stroke. Her functional level was decreased actually, and she's still not normal somehow. So they diagnosed her as some kind of an unspecified encephalopathy. They did all the viral CSF test. Everything came back as negative. So diagnosed as a metabolic encephalopathy of unknown origin at the time. But then what happened is that there was a discussion between the ER doctor, that's an emergency medicine. As many of you know that emergency medicine is a separate branch in US, so it's not same as an internal medicine. So ER doc, her primary care, or maybe nephrologist, if I'm not wrong, they discussed this case together and they thought that this is not normal. There is something wrong here. So let's send her to a genetic evaluation because I think we are missing something here. So we sent her to the genetic center at the Children's Hospital, Colorado here. Next slide, please. And what they did is that this is what geneticists does at the first visit, right? They are very good at like drawing the family pedigree. In a pedigree, you can see now, can you guys see my cursor? Because I think I'm not having a slide, so, or not. If I move a cursor here, can you see that? Or
Yes, sir,
probably
we
not.
can see that.
Oh, okay, perfect then. So this is the patient here. This is the patient, okay? And if you go up, that's a dad. Dad is living right now, and he is in the Philippines. The first girl that he got married to, she developed type 1 diabetes and died at the age of 57 from a stroke. And again, she required insulin, so that's how we think that it's a type 1, but who knows, right? And then he got married to another girl after the first wife died, but they do not have any kids, so no history after that. And I'm going to focus on the mom side. So on a mother side, look at that, everyone had a diabetes. Okay, every single person. And if you go back to the grandparents, then the mother's mother had a diabetes. Father died, but did not have any medical complications or medical diagnosis. So it sounds like the disease is coming from here. Everybody got infected. But on the maternal aunt side, not everybody developed diabetes. Okay, there are some people who did not have any diagnosis or they were normal at the time. And this is our case. So this looks like kind of an X-linked disease. Next slide, please. So X-linked had an encephalopathy, had a diabetes. So definitely now we are thinking in terms of mitochondrial. So we sent her DNA for a mitochondrial diabetes, and we found out to be have a mutation on mitochondrial DNA, which is a very typical mutation. Wait. Somebody had a probably too much of tea or coffee. It sounds like who is moving this slide, but take it easy. This mutation is very common. It's called as MELAS syndrome. So we all know, I mean, we read Harrison in internal medicine, and MELAS syndrome is very classical. It consists of a mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. Now, remember that all mitochondrial subtypes, they can develop diabetes as well, but it's called as monogenic mitochondrial diabetes. Why it's important? Because I think we can treat these patients slightly earlier in a better way, and supplementing with the two amino acids, arginine and taurine, can prevent those stroke-like episodes. So probably if we have given those arginine supplements to these patients earlier, probably patients may not have developed stroke. And these are like very cheap supplements, right? These are not costly. So I think diagnosing diabetes, it's very important at the early stage. Right diagnosis of diabetes, I would say, emphasize. Now, remember one thing is that even though the patients have the same mutation in the entire family, each person can have a different type of mitochondrial disease, because we call it a heteroplasmy, right? So depending on the organ, again, depending on the cells, there can be a number of different mitochondrial mutations. So let's say, for example, normal cell has 100 mitochondria. I'm just totally making this up to make this concept easy for you guys. So in one cell, you have 100 mitochondria, and only 10 mitochondria are mutated. That means it's a very mild disease. Now, if you have a 50% or higher mutated mitochondria within that cell, that means it's a probably very high high heteroplasmy of that mitochondrial mutation. So now I'm just going beyond that cell. So let's say, for example, there are a lot of mitochondrial mutations in the bone. That means that patient will have a bone manifestation. Now, this patient may have a lot of mutation in a pancreatic cell. So that's why this patient is manifesting as a diabetes. Now, there is a more mutations in a brain. That's why this patient may have a stroke. But remember that within the same family, the patients can have a very different manifestations, because depending on which organ has a more mitochondrial mutation. That's, we call it an heteroplasmy concept. Next point, please. So we revised the diagnosis, unfortunately, after 20 years treating her as a type 1 diabetes as now mitochondrial diabetes. She's not doing well, by the way, because her mental status level has declined significantly. This is a classical history of mitochondrial disease, that most people die between the age of 40 years to 60 years of age from a various complication. And now we also realize that her nephropathy was a part of the mitochondrial disease too. It was not diabetic nephropathy. It was a nephropathy because of a mitochondrial disease. Next slide, please. Again, the limitations of having this virtual conference with 30 minutes of dedicated slot is that I cannot keep speaking about that. So what I did is that I selected really good articles for you to read. I'm going to keep this slide here for probably 30 seconds. So if you want to take a picture with your phone, or if you want to write it down, feel free to do that. The particular the New England Journal article that listed here in the middle, I think that's a very good concept. Now we know that we can do a gene editing. So what we can do is that we can replace the mutated mitochondria when there is a fertilization. Immediately after fertilization, replace that with the normal healthy mitochondria, and probably we can prevent the transmission of the mitochondrial diseases. Very beautiful concept, but it will take some time to become a reality. But I highlighted this 4 articles here. Please read them if you are interested about mitochondrial diabetes. Trust me, we think that these kind of diseases are not common, but that's not true. If we don't know, we don't see. And so there is a saying that if you don't know, your brain doesn't know, then your eyes don't see that. So If you, so this was my first time diagnosing a mitochondrial diabetes in somewhere around 2015, and after that I have diagnosed now 6 cases of mitochondrial diabetes. That means that cases were already existing, right? It's just that we never diagnosed those patients earlier. I have a lot of different atypical type of diabetes nowadays too, including all different monogenic diabetes and various types of diabetes. So again, if you are very active, if you keep thinking about that, then you will find those kind of a diabetes. Next slide, please. So I call that any time in a science there is a learning, and it's nothing right or wrong. It's about that you have to learn, and there is no end to learning, right? So what I will learn from this case is that when you see patient for the first time, try to get the detailed history. The mistake that I made is that I did not take the full family history. Actually, I just asked about the mom and dad, and I ended there. I should have asked more about, what about the maternal uncles? What about the maternal aunts? What about the grandparents? Next, please. Never assume the diagnosis when the patient is referred to you. So let's say, you are the treating physician and the patient comes to you that, okay, I'm referring this patient to Dr. Kamlesh Pai because he's an expert in diabetes. Now the diagnosis of diabetes is type 2 diabetes. So when you see this patient as a type 2 diabetes, never assume that. Don't block your mind. Start as a fresh. Try to make all the differential diagnosis that is possible. Next slide, please. Classification of diabetes is very challenging. Trust me that, as I said earlier, that there are many patients that we see that we are still not sure what kind of diabetes they have. So in the United States, they have started a new clinical trial called as Radiant study. So what we are doing in a Radiant study is that all atypical diabetes in the United States, we're gonna probably call all these patients, their families and everyone, and we will do head to toe scannings, CTs and MRIs and whatnot you can think of. And they're gonna look at the whole genome sequences and try to identify what kind of a different diabetes that we are still not aware of or we are not able to diagnose. So it's the future will tell us whether Radiant is gonna be success or not. But it's very challenging. Next, please. Not all diabetes are type 1 or type 2. 10% of adult onset type 1 diabetes are generally misdiagnosed as type 2 diabetes. So if you do antibodies in all type 2s, about 10% of the patients would actually be type 1, not type 2. And about 1 to 2% of those type 2s are probably atypical diabetes. And I just took this from various sources. These numbers can be different depending on different studies. Next, please. So with that, I'm going to end this case. Thank you, and happy to get more questions. I got in chat that there are so many questions. So let's see if I can answer those questions. I will try to.
So there was an interaction from our scientific committee, and as you were proceeding, Dr. Mona Shah, who is scientific chair also, she thought of and she write it down that it looks like a mitochondrial aspect. And before you go to the pedigree part, she was so on her mode. So let's see. That was her comment coming from. As she could not join in from faculty side, she posted from the delegate side.
Yeah, sure. Her question is that whether we can do this genetic mutation in a leukocyte from a peripheral blood or not. The answer to that, I don't know. I think what I know is that once you think that this is atypical, this is something, send it to someone who knows it. And that's what I do. So if I suspect the mitochondrial, I send it to Dr. Van Hove. He has spent his life in a mitochondria for 40 years. So he does all the genetical analysis for me and then sends me back patient that, okay, this is the mitochondrial or not mitochondrial. So I think in my understanding, you have a mitochondrial mutations everywhere. Some cells have more than other cells. So they may do from a peripheral blood, but if it's not a successful, sometimes they do a biopsy of a particular organ and they also try to look at the mitochondrial heteroplasmy from those organs as well. But that's my understanding. I may be wrong.
Wonderful sharing. Yeah. So we thought of, but to go to the biopsy level and get it done and to investigate. Yeah.
Other thing that in an Indian side, I think a lot of people might be thinking that this is not possible in India. Don't think that. So ICMR has a monogenic registry. I think Mohan was in charge when I was there. I'm not sure who is the in charge right now. So if you are suspecting monogenic diabetes, you can send your sample to ICMR and ICMR can do a genetic testing. I have done like plenty. I have diagnosed a lot of monogenics in India too. The other options that you have is that all these people, when let's say you are suspecting a mitochondrial, like Dr. Yash is suspecting a mitochondrial, what you need to do is that find out the most recent article from journal, email to that particular author, because here it's very open. We are very interested in learning. Okay, we are very interested in trying to find out a lot of different things. And when I was in India, again, I have sent a lot of samples to the US, and people have done all these kind of mutations free to me. I have diagnosed a lot of various genetic syndromes when I was in India too. So don't think that it's impossible. It's possible. Just you have to be open-minded. Email everybody. There is no harm in emailing. What you're gonna lose is that they will not reply, right? That's okay.
That's true. We have Dr. Mahadev Desai sir, and he had a question. Please, Dr.
Sure.
Mahadev Desai sir.
Did she have lactic acidosis here? Or
yeah, she had. Yeah, we never actually. So when we do a CBC CMP annual, we don't check for lactic, right? So this was missed. She had a 2 or 3 hospitalization in the past, and the lactic acid was high. But then we thought that in serious conditions, in hospitalization, there are many reasons for an elevated lactic acid, right? So we never followed this case actually very thoroughly. So it was my mistake, and I learned something. That's what I can say, and probably I will not make that mistake again.
Sir, it was a wonderful session and we got to learn a lot. So, Sir Kamlesh Sir, Jitendra Sir, if you want to say something.
I'm happy to share the dais with all lifetime students, and we will definitely pick up this issue in the country. Sure.
Dr. Jitendra, sir, if you want to share something. You are on mute, sir. Dr. Jitendra.
Yes, nothing much. Thank you, Dr. Viral Shah and Dr. Atuk, Dr. Mayur Bhai, Dr. Yash. Thank you very much for inviting me to chair this session. Thank you.
I just saw Dr. Mayur Bhai, so I have to comment something. Dr. Mayur Bhai, it sounds like you are growing younger and younger every year.
Oh,
What's the secret?
It is because of people like you. You are
No,
always
that's not
energetic.
true. You are trying to
get
be nice.
inspired. I have always support like people from like Dr. Mahadev Desai. He's again a very energetic guy, even senior to me. Dr. Kamlesh, Dr. Jitendra, they are doing great in the field. So I'm always getting energy. And of course, from Swamiji, who demonstrated yoga in the morning. That is between 8:30 to 9 o'clock. So energy from young people, energy from all experienced people, I'm getting younger and younger. And especially not to forget Dr. Yash. He's driving me. Yeah, he's driving me. Maybe I would say pulling me. That's why I'm here. Thank you so much.
He is so visionary. He keeps us running. So it's like Rathma, Krishna પાછળ બેઠો, અર્જુન પાછળ બેઠો ને આપણે દોડ્યા કરીએ. Please. Yes. So.
Okay. Thank you very much.
Yeah. We can conclude the session. Yeah. Thank you, Dr. Viral, Dr. Kamlesh Upadhyay, Dr. Jitendra Nagav, Mahadev sir. Pleasure. Dr. Akhtar. Thank you everyone for making this morning so wonderful morning to Indian side, and hope you have better sleep. We have almost 2,800 plus attendees at present attending this session. Thank you.
Wow, that's a good number in a morning. So 2,800, that's a good number. Yeah, that speaks about the quality of this conference, and the people have a lot of expectations. So again, thank you for having
that too. Sorry to interrupt. That too from 20 different countries. Yesterday we have Zimbabwe Health Minister joining us. So there are multiple people from various nearby countries.
Wow, that's excellent to hear. Yeah. So thank you for having us, me and Dr. Akhtar as well. We both work at the same institution. So thank you.
Thank you, Dr. Atka. We'll see you soon. Hopefully next year or before that.
Thanks, everyone.
Okay.
Thank you very much. Bye.
Thanks, everyone.
Thank you so much. Now we'll proceed for the quiz. Yeah. So for the so there are certain instructions for the quiz. Click on the live poll icon at the top of the screen. Choose your desired option and press submit. The same process to follow for each quiz question, and we'll give 10 to 20 seconds to answer that question. So next slide. Which of the following oral antidiabetics is also available as an oral liquid or syrup formulation? Metformin, sitagliptin, gliclazide, and acarbose. You can answer that in the poll.
So thank you everyone for voting it out. And we have the quiz result running through. And the answer is A, metformin. Next question, please. And do we want to see the results in between? Or yeah, we can see the results. So plenty of thought of sitagliptin. Yes. So let's build on to the second question. So it seems sitagliptin is also coming up in oral would be in the liquid formulation. Yeah. So next question. Some Chinese herbal products meant for treating diabetes were banned because they were found to be contaminated with option A, oral GLP-1, option B, insulin, option C, fenformin, option D, pioglitazone. So the voting is open for you.
Okay, so we have the poll results here. The right answer for this is fenformin, and we are very much thankful to our faculties. They have taught so much good that almost 57% have the right results. So can we move for our next question? Third question for today's quiz is, who was the first person to document the effect of exogenous insulin in animal models? Your options are Langerhans, Polescu, Banting, or Nock. Your poll results starts. Poll timing starts now.
Okay. So can we have the result? So the answer is option B, Nicholas Poles, and most have we answered Banting, option C, but the answer is option B.